So I'm going to talk a little bit about white matter injury or white matter abnormality. And I really want to put it in context for you because I think part of the problem with what is going on in newborn medicine and the use of imaging and the holy grail of predicting every outcome is that we don't really stand back and think about what it is we're measuring. So I'm going to talk a little bit about what it is that you see in the literature or you may be involved in your own studies and work, a little bit about how common those things are. I want to take us back to actually thinking about what is the underlying abnormality in the cells that we might be trying to capture with our images. And then the real crunch of the talk was meant to be talking about neurodevelopmental sequelae, which I will. But I think I'll try and put it in a broader context of why it can't predict everything all the time and tell you a little bit more of the the very new insights we're having with imaging now and what that means for you as practitioners in the field. So many of you will be familiar with this type of diagram. This is from Joe Volpe. And these are the different terms that are often used here for white matter lesions. Many of us that are older in the audience are more familiar with the cystic PVL, these focal macroscopic infarctions really. They were loss of all cellular elements in the white matter. Often there was diffuse lesions as well, but sometimes these were very, very large. And now more recently we've focused on non-cystic PVL or periventricular leukomalacia, which as you know just means peri, around, ventricle, leuko, white, malacia, bad. So this is the diffuse form. Sometimes there'll still be focal abnormalities, but they're more microscopic now rather than the cystic lesions. The reason some of you are not so familiar with cystic PVL is over the 90s it was noted that there was a marked decline in the incidence of this lesion. And it's still not entirely clear why. But we could say there are a lot of changes in practice during this time, particularly in the North American context, a much larger use in antenatal steroids. I was somewhat fascinated over the last 3 years to have the privilege of a Japanese physician working with me. In Japan, only 30% of their infants receive antenatal steroids. Cystic PVL is still a very, very large problem within Japan, and I think it opens up opportunities sometimes for us to think about insights we may have from different practices across nations. Within the Vermont Oxford, however, cystic PVL has been pretty static in the 2000s, sitting just below 3%, so still a pretty uncommon lesion. What kind of things might you see in the white matter in terms of abnormalities on cranial ultrasound? Well, these are echo densities, as you're familiar with, in the periventricular white matter, and you can see them here rimming the side of the ventricle. What are these? Are they real? Do they really relate to outcomes? Well, we and others have studied these for a long time, and we did find in our own clinical practice that abnormalities on ultrasound within the white matter were not very predictive, and many other groups have published this too, of what we then went on to find on MRI. And perhaps more concerningly published from the NICHD was the fact that there was very poor consistency, even in looking at cystic PVL lesions on ultrasound by 2 study investigators in the same centre. So you do have to be careful with the ultrasound, depending on the level of experience and the reporting of those abnormalities. On MRI, it's a little bit more straightforward sometimes. These are what we call punctate focal signal abnormalities, and this is from Steve Miller's article. And you can see here there's just one little faint one, but here's a little bit bigger one, and here there's a whole bundle of them. Now, exactly what these are in terms of the pathology underlying them is still not entirely clear, and it may change over time. So very early on, there may be an element of hemorrhage, although it's not prominent. But certainly by the time you get to term equivalent, these may well represent some form of scar or gliosis. But no direct pathology to MR comparison in human infants has been done. This is the so-called DESI, diffuse excessive high signal intensity, And you can see here, this is a healthy preterm infant term equivalent. Here's all the white matter, here's the grey matter on the outside, but the white matter looks very uniform, very kind of even grey, whereas here you can see it's not very even. This colouring in wasn't quite so good, and also it's very bright. If you look at it compared to CSF, it looks like it's got a much higher water content. And this was initially reported by the Hammersmith group as occurring in up to 3/4 of their babies, and at 2 years appeared to be predictive of outcome, but no subsequent insights have come after that time. When we looked at white matter abnormalities, that I'm going to show you outcomes on, we looked at a combination of all these things. So we looked at these little signal abnormalities, but we also looked at more diffuse abnormalities. So you can see here how the white matter volume has been reduced. The corpus callosum is extremely thin. The ventricle is enlarged. So these were all things that added up, as we'll talk about in a scoring system, that allowed us to give an overall indication of the amount of abnormalities in the white matter. So why is the white matter so vulnerable to injury in our premature babies? Well, the white matter is maturing at a rapid rate. It's going from these little axons here that are all disorganized, they're lining up. And then the key cell that we're going to talk about is this little guy here, the oligodendroglia. Really fancy name for a little tiny cell. But this little cell is going to line itself along the axons and produce a lot of myelin to encapsulate the axons. So it starts off, the little oligodendroglia actually is a neural stem cell that can form into anything, goes through a progenitor, then an immature form where it still isn't, it's getting ready to produce myelin, but it hasn't done it yet, and then a mature myelin-producing cell. The reason that our babies are so vulnerable to injury in the white matter is exactly due to this cell, this little guy here, the pre-oligodendrocyte. What is this cell vulnerable to? Well, the two big mechanisms of injury appear to be inflammatory and ischemic. Ischemic, I'm sure you're all familiar with. We obsess over blood pressure and worry about ischemic reperfusion injury. And inflammation has become increasingly clear as a pathway for injury to these cells. How does the injury occur? There's been a lot of beautiful cellular work that's shown what they have to do is activate the white cells within the brain, which are called microglia. And you need this to happen because these will then produce free radicals, cytokines. Other cells will produce glutamate, and that combination will produce death in these cells. So these cells go on to have a large amount of cell death in combination. So if you're looking at the inflammatory pathway, which is perhaps less well known than the ischemic pathway that we all think of, what is actually going on? What is happening when a baby's brain is exposed to systemic inflammation that would lead to the loss of this cell type? Well, the key mechanism is actually through this thing called the toll-like receptor. And it sits on that little microglia, that little white cell, and is activated by the immune system. Now, it's not activated by necessarily the organism itself. What it's activated by are these pathogen-associated molecular patterns, or PAMPs. And different organisms have different signatures, or PAMPs, that activate different types of toll receptors. And that's why different types of organisms have the capacity to have different types of effects on the central nervous system. So if you look at lipopolysaccharide gram-negatives, which we all are afraid of, they activate one of the most potent toll-like receptors, TLR4, whereas coagulase-negative staphylococcus also has a PAMP signature, but it has a different type of motif that binds to a different type of toll receptor. So each of these toll receptors can elicit a different degree of reactivity, if you like, in the microglia. But they all produce upregulation of free radicals. The important thing to realize is that you don't have to have the organism within the brain. You can, because of the immature blood-brain barrier, but that's much less common than this signal actually just being propagated through other mechanisms. So you never have to have the organism, actually even in the baby, to potentially propagate a signal that will damage the cerebral white matter. So if you're trying to see cerebral white matter injury, what kind of imaging methods or techniques are going to actually let you see this pathology. So we know we've got these microglia activating pretty quickly, first 24 hours. Then they're going to proliferate. We're going to see our cells dying. And then following that, there's going to be a long period where we start to get scarring. Because of the loss of these cells, we're not going to have the wrapping and the production of myelin we expect, and so we're going to see myelin deficiency also chronically. So what out of all of these things can we actually see with imaging, and which imaging techniques allow us to see those things? Well, to get at that, we had the privilege of working with a premature baboon model. And on the top here, you can see images of the baboon at the time we started experiments at 125 days, which histologically in imaging was similar to 27 to 28 weeks, 114 days and 153 days. So you can see how similar, in many ways, this particular model is to the human premature infant. What happened in this model was we had a lot of background data about what was typical in brain development, and then we had some experimental interventions at different time points, and we looked at patterns of injury across those times. Often the baboons were delivered around 125 days, and this is 3 different studies, not 3 baboons, that accounted for about 30 baboons. And the mothers were given antenatal steroids. They were delivered by elective cesarean section. And then we had the animals alive for usually 14 or 28 days, and then they were euthanized. And we looked at the histology, and we also undertook imaging of the primate brain. So we would look for the same sorts of things we just talked about in human babies. We would look at whether there was any white matter abnormality, this baby has none, or whether we saw focal abnormalities, enlargement in the ventricles, or loss of the white matter volume. And then what we tried to do was look at the same things on histology. So we measured volume, we measured ventricular volume, but we could also look at these cells. So we could look for these scar cells, these astrocytes. Here they are here, they're little kind of spidery looking things. And we could also look for the oligodendrocytes. And you can see one here where it's lying with all of its processes coming out to wrap around the axons and produce myelin. So what did we find about what imaging means in terms of these underlying, You can see here. So here is the imaging characteristics, and here is the histology. And these are just things you would conventionally look for on your images. So this is this high signal in the white matter, loss of volume or enlarged ventricle, and this was the total abnormality score. And what you can see is, yes, if you had loss of volume, it related to loss of volume, but it wasn't very sensitive at all for these abnormal scarring cells or loss of that critical cell that we're most interested in. In contrast, and this is very busy and it's just meant to give you a concept, these are measures on diffusion-weighted imaging. So as you know, diffusion-weighted imaging looks at the movement of water, and from that we can measure how far the water moves by a thing called the apparent diffusion coefficient, or we can look at the orientation of the water movement called relative anisotropy. So these are just 2 measures that we get off, and anybody can do this. On your own scanner, you just put a little circle over your diffusion image and up pop these 2 values. One on your diffusion map and one on your anisotropy map. And what you can now see is that actually look at anisotropy in relationship to these cell types that we're most interested in the loss of. So anisotropy was telling us a lot about the loss of these cells, these critical oligodendrocytes, and diffusivity was telling us a lot about the presence of this scar tissue. So diffusion imaging is much more sensitive than conventional eyeballing of the images. So in summary for that baboon model, we really were impressed that there were some abnormalities that reflected the changes you see in the histology, and particularly these changes in T2 signal and changes in the diffusion measurements reflected the scarring, volume loss, and an enlarged ventricle. This particular measure of diffusion that contributes to anisotropy looks at how far the water moves outwards. So you can imagine if you're wrapped around a little cable, then you're not going to move a lot outwards, right? Because you're just going to move up and down because you've got that wrapping around you. And what we found was that if the wrapping wasn't present, you had a lot more water movement that way, and that really related to the loss of this critical cell type. And finally, anisotropy, as we said, also related to that loss of that cell type. So we thought this was important to then point us back to what we should look at in the human. So when you look at the history of how good imaging is at predicting outcomes based on white matter abnormalities, this is what is out there. So let's start with cranial ultrasound. Well, cystic PVL actually is very predictive of cerebral palsy, with a range between about 60 and 90%. Overall, if you see cystic PVL, there's about a 75% chance that that child will have cerebral palsy of some dimension. What about more mild abnormalities on cranial ultrasound? Echo densities, ventricular dilatation. Well, these have been related to developmental delays, but only very early, and also within the EpiPage study to increase risk of cerebral palsy, but again, with nowhere near the potency that this finding of cystic PVL has. More interestingly to me, in the last year and a half, there's an increasing amount of data coming out about behavioural abnormalities in these kids related to ultrasound abnormalities. So we've been a little bit slow to pick up on the fact that things like attention deficit, tic, obsessive compulsive, and even major depressive disorders are much more common in our ex-preterm infants than term-born controls. And it did appear in this beautifully written article that the presence of either IVH or white matter abnormalities was associated with an increased risk for these minor and major psychiatric issues. We looked at our own data and also found that persistent echo density for more than a week was associated with positive screenings on autism, and we're just finishing the full evaluation of those children, and lower competence on the social emotional assessment at 2 years. So there does appear information that's important on ultrasound that we should be paying attention to, but it may be more in terms of this behavioural spectrum. For MRI, we looked, as I said, at a combination of abnormalities, signal, size, and then we classified them into children who had no abnormalities, which is about 25%, mild abnormalities, about 50%, or moderate to severe, which combined were about 25%. And what you can see is that the scores on the Bailey 2 go down as the severity goes up, and that the chance of having significant cognitive delay doubles, and motor delay in particular with these more significant forms of white matter abnormality. And when we summarised out those findings, we felt, like others have, that cerebral palsy was fairly well predicted, actually, with good sensitivity and specificity, but these cognitive deficits were still lacking in terms of their specificity. So we felt that the MR and white matter abnormalities had the stronger predictive value for motor than cognition, and that feeling still persists. Although what we have done now is gone on and analysed these children at 4 and 6, and this is data that's currently under review. So this is the same categorisation for the abnormalities and the white matter, and these are only cognitive outcomes. So this is IQ, essentially, language, and executive functioning. And what I want you to note is twofold, and I'm going to show you the 6-year-old data in one moment. If you look at children that had no white matter abnormality, which is about a quarter of this cohort of very preterm babies, there is no difference from full-term, geographically matched controls. And there are 23-week infants in here, by the way. So, you could control this for every other risk factor, but if your white matter looked really good, it was a good biomarker that your brain was in good shape, and at 4 years you were indistinguishable from a term baby. The children with mild abnormalities showed a little bit of a deviation, but it was only really significant for total IQ, whereas those with moderate to severe abnormalities, about 25% of this cohort, showed a significant downward deviation at 4 across all domains. A similar pattern was seen at 6. At 6, fundamentally, if you didn't have white matter injury, you did not differ from term controls. But now, particularly for things like executive functioning, at 6 years of age, we start to see those mild children deviate a little bit away from those children with no abnormalities. They're not striking differences, but if you look at the amount of children with any delay, or you can see here 40% versus 30% versus 60%, or severe cognitive delay, you can see here up as high as 40%. So it persisted with mild, moderate, and severe abnormalities deviating children away from their term-born controls. One of the types of abnormalities we talked about was DESI, this diffuse excessive high signal intensity, and we tried to better define this by making gradings, which can only be done qualitatively by the eyeball, saying, gosh, if it's, a little bit more, quite a lot, but sort of only one region of the brain, or diffusely across the entire brain, how does that relate to outcome? And this is what we found, no relationship. So this particular finding of DESI has now been removed from all of our scoring systems because we feel that it's lacking in sensitivity to really have any predictive value. And the only way we'll know that for sure is by the time we get to our 12 and 15-year-olds, but it does not seem to be a significant contributor. In contrast, as you know, all of these things we believe are significant contributors to outcomes. So we've already talked about cystic PVL here. This is linear hyperintensity involving all of the white matter here. These are focal signal abnormalities, but there's more than one, and here you've just got one, barely two. So we graded again based on the extent of signal abnormalities only, IVH traditionally, and then cerebellar hemorrhage, which for those of you who are undertaking MR in your very, very preterm infants is becoming increasingly visible, small unilateral, small bilateral, large unilateral, or large bilateral hemorrhages. We reclassified all 340 infants that we'd previously classified with our old scoring system, looking just at this. Let's just look at injury. These are pretty traditional forms of injury. Let's just see what that does for predicting outcome. So the first thing I want you to note is that there were 220 babies who did not have any grade of any injury at all, and already you can see on the Bailey 2 that their MDI score of 86 is not where you would want it to be. 28 of them, or 14%, had an MDI less than 70. This is no injury, right? And indeed 5% of them had cerebral palsy. So when you look at the remaining infants who lie within these other categories of injury, you can see here the coloured in ones are the ones who significantly deviate from the infants with no injury. And you can see, as you'd predict, grade 3 and 4 IVH, grade 3 and 4, i.e. this linear hyperintensity or cystic PVL. And cystic PVL was, or this linear hyperintensity, very high rates of cerebral palsy, whereas IVH more like 50-50. We didn't have sufficient infants so far, but we will in our next cohort, I'm afraid to say, to look at this cerebellar hemorrhage in more detail, but at least the low-grade unilaterals did not seem to deviate significantly from the children without that lesion at 2. So what does this mean? Well, look, how many babies are there in this out of our entire cohort? You're talking about 25 babies out of 340 babies who are showing us a reason for their deviation, and all the rest of them, there's something else we're not capturing by this fundamental injury score. Could this be because there's a lot more going on within the whole cortex? And again, this is from Joe Volpe's review in The Lancet, which is a beautiful review. So we've talked about axons and pre-oligodendrocytes, but there's subplate neurons, there's the cortex, there's the deep nuclear grey matter, and of course there's still areas within the brain that are producing immature interneurons that are yet to migrate out. And all of these areas are connected to each other. It's an incredibly complex system. So are we naive when we just say, well, gosh, we're going to look for a bit of IVH down here or a bit of cystic PVL and predict everything? How can we better capture this? Well, that has to turn us away from spending all of our time looking at brain injury and start to think about this in inverse ways. So really, brain injury, as I showed you, is accounting for probably 10% of these infants and their poor outcomes. And brain development, this much bigger elephant in the room, is accounting for the vast majority of the outcomes. So how do we capture that? Well, we noticed a long time ago, nearly a decade now, when two babies came to the scanner on the same day. They were both born at 27 weeks, believe it or not. Their parents were so excited because all of their cranial ultrasounds had been reported to them as normal. And we scanned these two babies and we were like, you know, this one doesn't look like the other. But what is this? You know, what has happened here? Why does this baby have a beautiful brain that fills the skull with these beautiful posterior limbs and white matter volume, and this baby just looks like someone really sort of left something out? So in trying to define this, you've got to step back, because this is where we're going to be able to have a lot more potency for predicting outcomes. So we've started to look at brain growth. We now have a few manuscripts that are out looking at simple measures you can do yourself on a scan, measuring the width of the brain, the so-called biparietal width, and the interhemispheric distance, and these correlate very strongly with much, much more complicated volumetric techniques for either CSF or for brain volume. And we have amended our scoring system, hopefully for the last time, but we feel this is a much less subjective scoring system, and we're happy to share it with anyone. But the white matter now we classify still for cysts and focal abnormalities now, these T1 abnormalities only. We look at myelination delay in certain regions, the posterior limb of the internal capsule, the corona radiata. We measure how thin the corpus is and grade it. We measure how big the ventricles are and grade it. And we measure a parietal width to look at how much white matter volume there is. And we can add all of those scores together to get an overall scoring system. But apart from the white matter, we are also now scoring cortical grey matter for signal, a very crude measure of looking at how folded and whether there's increased space. We also look at the deep grey matter, an area I think we've ignored to a certain extent. We look at volume reduction. And the same for the cerebellum. We don't just look at hemorrhage, but we look at how well a cerebellum's grown. So what do those things give us when we look at our children and outcomes? Well, this is a large cohort of infants we looked at recently with this scoring system. And you can see, again, about 20% of them have moderate to severe abnormalities in the white matter. But look, 20% had abnormalities in the cortex, a quarter in deep nuclear grey matter, and a quarter in the cerebellum. When we looked at it in relationship to outcome at 7 years and 227 preterm babies on their term MRI predicting outcome, and these are, as you can see, cognitive outcomes we're looking at here, IQ, spelling, well, there's motor here on the MABC, reading, math, and then behaviour by strengths and difficulties questionnaire. This is controlled for 15 other factors. So it's controlled for gender, gestation, length of ventilation, postnatal steroids, PDA treatment, sepsis, all of those things, antenatal steroids, all of those things thrown in there. So in other words, what does this give you in addition to what they don't? And what you can see, interestingly, is yes, moderate to severe white matter is still important. It's still out here as an important driver of outcome. But look at the deep nuclear grey matter and look at the cerebellum. These are important areas of the brain, in addition to white matter abnormality, that when there is abnormalities present, are going to drive outcomes for our children 7 years after we let them go from the neonatal intensive care unit. So this is still powerful. The mild abnormalities, yes, they still deviate away from the norm as well. And these are compared to children with no white matter abnormalities. And if you combine them all together, look at the driving force you can have on things like math and IQ when you combine them, somewhere between a 10 to 15 IQ deviation downwards. So the picture isn't entirely clear just from the white matter or from the grey matter for several reasons. One is just eyeballing the brain is not enough to be able to see what's really going on. This is a different way of looking at the brain. These are comparing the surfaces of the brain or the volume of the brain between 24 very preterm babies and term-born subjects at 7. Now what you can see here is what we call a sulcal depth comparison map. So this area here in the temporal lobe is shallower in premature babies, or at 7 years of age. So prematurely born children at 7 years do not have enough folding in this area along the temporal lobe, or in this area here, straddling into the dorsal prefrontal. The same, they don't have enough surface area here in this region, and somehow they overcompensate with an increased area in the cingulum relative to term. And you can see a similar pattern for the volume reduction, all along the temporal lobe here into the parietal and this dorsal prefrontal swatch. These are the areas of the cortex that have selectively been affected in prematurely born children. Now, what does that mean? Does it mean anything? If we can't predict all of cognition just looking at the white matter, maybe it's because we haven't yet been able to capture what this means. And what we did was looked at just volume changes in relationship to function at 7. Volume changes at 7, how did they relate to function at 7? So receptive language was associated with reductions, or receptive and expressive. The reductions along here, that area where we saw the big reductions, they were related to impaired performance in language, both hemispheres. In contrast, things like attention difficulties related to these differences we see in the cingulum. So to really be able to get at these higher cognitive processing functions, we're going to have more than just looking at the conventional imaging of white matter abnormalities to really be able to capture the complex tasks that are here. But it does appear that the white matter abnormalities may be a reasonable biomarker. Now you might say to me, well, that's all very well, but do we have to wait to 7 to image these children, and then at 7 we can tell them how they're doing at 7? Well, actually, it's more interesting than that. So here is that data. This is the difference in the depth of the sulci along the temporal lobes. Here is the data leaving the neonatal intensive care unit. Look at the similarity in pattern. Even more strikingly, these are Australian-born males and females. These are American-born. So no matter where they were born, what type of genetics and environment and neonatal intensive care unit they grew up in, this temporal frontal vulnerability is really striking. Just to touch, other techniques are coming down the pipeline that you will see being applied to try and predict outcomes. This is neural networks by resting state functional connectivity. This is when you put a little seed in the deep nuclear grey matter, you see who else in the brain is playing in tune with your little seed. And in the term-born baby, you can see the motor strip and the cerebellum, and they're all like really excited and want to play in the same kind of way. Whereas in our babies, those connections and networks aren't established. We can take that and compare groups, and this is a very fancy learning method by machine learning methods to say, okay, let's take all of the neural networks and all of the premature babies and compare them to term-born babies, and how are they different? And you can see this left temporal lobe again standing out as a big, big area of difference. So in conclusion, I know that's been a bit of a broad strokes travel through white matter injury, but I think it's important for you to understand some concepts about brain injury as a whole in the premature infant to understand how to put this into context. So white matter injury is common. You understand why these little vulnerable oligodendroglia are very vulnerable to injury at this time in life. A negative ultrasound does appear in recent data to be quite predictive of a negative MRI, but I'll put this in some inverted commas because it really depends on the quality of the ultrasound and the quality of the person interpreting it. But certainly you've seen that a negative MRI does represent minimal risk, and in fact those children may go on to do as well as term-born siblings. The extent of white matter injury might be difficult to predict sometimes, and the reason being people are using a lot of different terminologies. And I would say that if you want to start classifying and looking at your white matter abnormalities on MR, which I would encourage you to think about doing, then I would, say find a scoring system that you're really systematically happy with and apply that. Don't let people just start talking about, loss of volume or some focal signal abnormalities, because any of those individual components are not going to be very predictive or helpful for you. MR is a more powerful predictor than clinical or cranial ultrasound factors, and particularly now if you combine these predictors for white matter with predictors from the deep nuclear grey matter and the cerebellum. And from my point of view, there's been a lot of debate, particularly within the European literature within the last month, about whether MRIs at term are merely anxiety-provoking for parents rather than giving information that could be of use. And to me, it actually is of use, both from the point of view of talking with families, but also from the point of view of actually us understanding what we are putting out of our neonatal intensive care units. How much cerebellar hemorrhage do you actually have in your unit? How much white matter disturbance? What does your brain growth really look like? And then we can start to have language that can compare our outcomes. From a research point of view, I think we're starting to understand who, what, and why. And obviously these improved imaging methods using neural networks and the support vector machine can actually take other clinical factors into it. It doesn't just have to take imaging characteristics. So we're starting to have a broader appreciation of the encephalopathy of prematurity, and that will help guide us quite a bit to understand how to predict outcomes in a better way. But I thank you for your tolerance for the breadth, and as you can see, actually this guy did have pretty good looking white matter. Thank you.
Still developed cerebral palsy, if I